And I thank all of the speakers for that session and particularly for staying to time. So if they could join us down the front, and we can now take some questions from the floor. So as you're thinking of your questions, pop your hand up and we'll make sure that we get to you. We've had a question come in from the auditorium. Peter de Hoog has asked, and I think probably Jackie and Andrea might be the best ones to answer this. There's a suggestion, Peter would like your comment as to the suggestion that the presence of a CAM-type deformity may well be a risk factor for a subsequent ACL injury. Do you have any comments? Would you like to agree, disagree? What would you say to that? Anyone want to jump in on that one? Or it's not something you're aware of?
It's plausible. What was it? Hand lesion, ACL injury?
Yeah. Peter has made the suggestion he'd like to hear our comments as to the possibility, plausibility, or thoughts regarding that.
I can answer it. Go for it.
As part of our prospective study, we're actually examining the radiological features of FAI. So in a couple of years' time, we will have the data to answer that question of whether radiological features of FAI are an increase your risk of developing ACL injuries, because we will be also measuring, as we do all of the injuries in our Qatar Stars Leagues footballers, we will be measuring ACL injuries.
So watch this space. And Jackie?
The only thing that I would say is that most of the work in FAI has been done in males, and I'm assuming your cohort is male. And it would be interesting to look at that relationship, obviously, in the females, where you're going to have more injury cases. So that's just a thought.
Okay, while we're waiting... here we go.
Tim Tyler from New York. That's some awesome work, Andrea. Great job. I was wondering on your hip range of motion stuff. I saw that you were looking at internal rotation, Andrea. What about external rotation? Do you think that plays a role? I'm not so sure it does. I've never looked at hip rotation in any of our studies, but I wanted your thoughts on that. Thank you.
Thanks, Tim. Actually, when we were deciding on the test to use for the study, part of our decision was made on time basis, because obviously we would like to have used more and more tests to look at some of these other more obscure questions. And you're right, hip external rotation has only been shown to be predictive in one study, and it was actually pain and not range. So we didn't include hip external rotation in the first year because of that reason, because the footballers are subjected to many, many tests, and we wanted to try and make the time as efficient as possible for the screening process. However, this year we have included hip external rotation. So this data that I presented today is from last year's screening, 345 footballers, and we have another at least 345 from this year. So we will have one season of prospective injury surveillance in those footballers as well. So it'll be interesting.
It had always struck me as odd, but perhaps because the hip is maybe 10 years behind the shoulder, that the hip guys are looking at one end of the rotational range of motion spectrum rather than the entire total rotational range of motion. And Rincha had pointed out previously that in the humerus, at least, the whole rotational range will be twisted by inter-individual and within the individual variances in the amount of twist in that bone. I can't see why the hip wouldn't do the same thing, or the femur. So just looking at one end, as Tim says, makes perfect sense, and perhaps some of these guys will self-select towards sports that require certain rotational ranges of motion.
As I said, we looked at the literature and we chose the tests that were shown to be most predictive, and we did a Faber test as well, looking for pain. So in effect, that will pick up the pain with external rotation in conjunction with what's found in the literature.
So we have a question down the front. If you could just perhaps grab the microphone.
Hi, I'm Hema from South Carolina, USA. Thank you so much for a wonderful presentation. From morning, I have been really, really impressed and enjoying. My question is, do you also look at the SI joint instability and ankle instability?
We don't have any test specific for the sacroiliac joint. We do have measures for ankle dorsiflexion range.
Oh, okay, thank you.
You're welcome.
We have a question over here on the left.
I'm Hannu Paajanen from Finland. I would like to ask Dr. Agricola, because this CAM lesion is so frequently seen in young soccer players, how often it is painful and how painless? Obviously, usually it's not painful, or what do you think?
Well, what we found in our prospective studies in which we studied football players from 12 to 18 years, there's no association between the presence of a CAM deformity and pain. But the idea is that pain due to the CAM deformity is caused by, for example, labral pathology. And in this young age, we assume that labral pathology has not yet occurred. There are some studies, a recent study from Khanna et al. And another study from 2008, who showed in the general population an association between a CAM deformity and hip pain, but associations are quite in the range of about, odds ratios are in the range of about 2.5. So definitely not all CAM deformities will give hip pain.
Okay, if I could jump in perhaps. So following up from Jackie's presentation on risk factors, it struck me as odd that I think by definition an overuse injury is a training fault. You've given somebody too much training than they were able to do, and yet nobody seems to have really looked at the loading profile for these as a risk factor. We're looking at a whole bunch of other things, and if you go and double, triple, quadruple the amount of training or practice that somebody does, it's hardly surprising that these people get injured. Why do you think there is this gap in the literature or this unexplored area?
Exactly, and that's why in my very last slide of my limitations I said that the review is obviously limited by what's been looked at, and maybe something that hasn't been looked at is that. So I would agree it could be the overtraining, though one thing to consider is in some of the studies they have adjusted for exposure. So that is sort of incorporated in that a little bit, but I agree with you 100%. The other thing is just looking at physiological fatigue or measures of physiological fatigue or overtraining. We've just done a systematic review actually looking for lower extremity injuries in dancers, and there has been some work done with respect to that in that population. But they're a very unique population and it doesn't necessarily apply here. But I agree. I think that that is actually something very interesting to look at. And I would argue that there are probably a lot of elite level athletes where we are actually tracking physiological measures of physiological fatigue. And we're using that to determine how they should train and what they should do on that particular day. But I haven't seen that necessarily in the research around specific to groin injury.
And finding those specific markers for the individual athletes might well matter. I saw Roel just twitch there because I suspect he's going to want to talk about exposure as opposed to exposure as a general idea rather than individual exposure here.
And you're wrong. Yeah. But I'd like to follow up on this with a specific question to Rinche and then a more general question to all of you. I'll do the specific one first. Now, you presented the finite element model of the loading pattern of the hip. Is there any data on the prevalence of CAM lesions in jumping athletes, so say high jumpers, volleyball players, where the hip sees much higher loads and much higher volume of loads? Or would you comment on that?
Well, actually, to the best of my knowledge, no, they are not. If somebody in the audience knows papers, but no, there are no papers that study the prevalence of CAM deformities in jumping sports. But while the loads on the hip in jumping sports might be higher, we think that it are more the rotational loads on the growth plate, so the more the shear stresses on the growth plate that cause the development of a CAM deformity rather than the static longitudinal loads.
So in other words, one way to address that issue would then be to test your hypothesis would be to look at the prevalence of CAM deformities in, let's say, volleyball players where there's high compressive loads in jumping. Where we see from other, if you look at bone mineral density, for instance, there are clear studies showing that these bone adaptations are very specific to the loading pattern of the various parts of the skeleton. Now, the general question, which may perhaps be the last question, is to all of you. Now, with all of you having, that's not me singing, no. Now, all of you have talked about the risk factors, and you've covered the intervention studies that we've done to date to prevent hamstring.
We're not finished.
Okay. Groin and hip problems in athletes. Now, with the evidence presented this morning, I'd like to challenge you with a question. You said with the data you have, I quote, "This provides opportunities for prevention." Now, to all of you, where are the opportunities for prevention? What would you speculate? Where should we go? I'd like to give you your point of view as of this morning. What's the next step? What should the clinicians, the team physicians here be doing today to prevent groin, hip problems with their athletes?
Well, I can reiterate what I said on my final slide very generally. I think one of the things that I really liked, and Martin reiterated, was the Engelbert study where they particularly delineated people into high-risk athletes and non-high-risk athletes. So I think that we may have more success down the road as far as in our intervention studies showing an effect if we do target people that are at risk. And that sort of radiates my comment about FAI and ACL. We have to look at the right injury in the right population to have enough injuries to be able to determine if we're actually having an effect. So I think targeting at-risk athletes is important, and I think that, obviously people that have had a previous injury are at risk, perhaps if they play at a higher level. And then, I think also individual trainers, clinicians, physicians, physiotherapists would also have an inkling that, there may be other things that they think make somebody at risk, and to use that in your judgment, whether it be how they're functioning or their clinical exam. So identify athletes that are at risk. What we do with them, I think, I can only reiterate what we found in the review, which is I think obviously, and I think everyone is saying is, adductor strength is an important piece, but I wouldn't say obviously that that's the only thing. And then the one thing, and I know that I brought it up and it wasn't necessarily something that came up in the other studies, was, and it's based on a study that was done by Carolyn Emery and Winnie Wissa looking specifically at ice hockey, but I do think there's a piece around sport-specific training, whether it be preseason or off-season, and I think there's something to be said there. I get that in a lot of high-level athletes and high-level leagues, there isn't a lot of an off-season, so that maybe brings in the piece around the physiological fatigue, but I do think that that piece is important. So that's my thoughts.
I'd like to continue that in saying that if we have a consensus about how to clinically diagnose various entities of groin injuries, we can also study the etiological factors behind these specific diagnoses and probably have more directed interventions toward those risk factors. And the second one is I like to build on what you said, Rod, is that there's very little data on extrinsic factors, and I think we have good data that training and match load is significantly associated with various tendinopathies and tendon problems and also acute muscle injuries. So there's no reason that training and match load shouldn't be an important factor also for groin injuries. So monitoring of external and internal loads among athletes is probably a key issue for prevention, I think, among the teams.
We have some time left. Well, I think in CAM deformities are only one part of the hip and groin pain, of course. But when you look specifically at that part and you look at prevention, then you might think of in the period in which the bone growth is most responsive to hip loading, you might think of interventions, let's say between the age of 12 and 13 years. And if there are better studies confirming the results of the finite element models, then you can think of in that specific age range for different kind of training, different kind of loading patterns. For example, instead of 5 times playing soccer, play 3 times soccer and 2 times on a bicycle for your condition, something like that.
Yeah, I'd also like to reiterate the importance of load monitoring. So we will have some data on the extrinsic risk factors in terms of exposure for our prospective study as well. And we will analyse the data looking at the training stress balance as developed by Tim Gabbett's work in Australia. So we will have some information about when it's more likely that athletes will develop groin pain, and then that will then quite clearly lead into injury prevention programs looking at load monitoring. And I think particularly looking at Olivier's and your work, there is opportunities for looking at load monitoring in those particularly vulnerable times of the athlete's development.
Okay, and with that we're going to finish up this first session this morning. Now, in the theme that exercise is medicine, we've placed the lunch quite a distance from here, and you're going to need to follow the Pied Piper, who's Diana Sheck, who's wearing a light green top. So as soon as you get outside, find Diana, follow the crowd, follow your nose, and we'll be at lunch and be back here on time to start for the next session.